Today I'm going to talk about lung cancer. Lung cancer is the commonest fatal malignancy in the UK for both male and females. It has a poor prognosis, as the symptoms of lung cancer can be non-specific. These symptoms include breathlessness and cough. 90% of lung cancer is linked to smoking, whereas other causes include asbestos. Most lung cancers are bronchogenic, and lung cancers can be divided into non-small cell lung cancer, making up 80%, and small cell lung cancer, making up 20%. Of the non-small cell lung cancer, squamous cell carcinoma is the most common. Squamous cell cancers are associated with the atopic production of parathyroid hormone, and therefore they may be detected in patients who have hypercalcemia. These cancers tend to metastasize late, and so can be operated on. The second most common type of non-small cell lung cancer is adenocarcinoma, and it is the most common type in non-smokers. Whereas the squamous cell lung cancers are located centrally, the adenocarcinomas are located peripherally. Now on to small cell lung cancers. These are very chemo-responsive, but nonetheless they will have a very poor prognosis. This is because they metastasize early. Squamous cell carcinomas or small cell carcinomas rather are associated with a lot of paraneoplastic syndromes, and they're associated with the secretion of ADH. Now this is a hormone normally in the posterior pituitary. Well, normally the posterior pituitary will secrete this, and the purpose of it is to absorb water from the collecting ducts. And this will give euvolemic hyponatremia, as water is absorbed and the sodium in the blood is diluted down. Small cell lung cancer is also associated with the secretion of ACTH, which gives Cushing's disease, and rarely it can give Lambert-Eaton syndrome or disease. This can be caused by small cell lung cancer, as the antibodies the body produces against small cell lung cancer also target calcium voltage channels in the presynaptic area. Now moving on to the clinical features. How would we know if someone had lung cancer? Well, they might present with breathlessness, cough for greater than 3 weeks, chest pain, a hoarse voice due to recurrent laryngeal nerve palsy involvement, and 20% of lung cancers present as superior vena cava obstruction, and this is when the tumour compresses on the superior vena cava, so a patient will be very breathless, they will have facial swelling and arm swelling, and they'll have distended veins in the neck. And they may also have shoulder pain if the tumour is located in the apex of the lung, also known as a Pancoast tumour. This sort of tumour can also lead to Horner's syndrome, and if there is superior cervical ganglion compression, and it'll cause ptosis and meiosis, and generally symptoms of the eyes. And what investigation should you do for lung cancer? Well, you should do a full blood count, all your routine bloods, as well as a bone profile, because you want to pick up is the calcium low or high rather, sorry, as parathyroid hormone is secreted in squamous cells, lung cancers, so that would give a high calcium. And you also want to check the chest x-ray and a CT thorax, abdomen and pelvis, and you do this with contrast. Also, it is getting more and more common to do a CT PET, and this is particularly important if you're thinking that the lung cancer can be cured. And CT PETs work by introducing a substance called 18-fluoro-2-deoxyglucose, which is an analog of glucose and is taken up by areas in the body which are very metabolically active. So they'll be taken up by tumour cells. It's not reliable for detecting brain mets, as the brain will take up a lot of this substance anyway. And it's not good in people with poorly controlled diabetes, because you're introducing a lot of glucose into the system. But it is good at showing us the actively dividing cells, metabolically active cells. It can be poor at detecting slow growing tumours such as adenocarcinoma, but it does have its important uses. Also, other tests that are of use are fibre optic bronchoscopy, and this is for central lesions, whereas CT or ultrasound guided needle biopsy is for more peripheral lesions. And the management of lung cancer is quite complex and constantly evolving, and the patient should be referred to a specialist. There would be MDT input. Surgery is the only really curative option. You can have a lobe removed of the lung, or you could have the entire lung removed, and you could also have chemotherapy and radiotherapy. As I've said before, for small cell lung cancers, they are very chemosensitive, so chemotherapy is the way forward for these lung cancers. But again, the prognosis for lung cancer is pretty poor, and is an area that's been the subject of a lot of attention to improve the prognosis in lung cancer. So thank you very much for listening to this video. That concludes the video, and if you like this video, don't forget to click the like button and subscribe to this channel to see more medical educational videos.